Thank you very much for the kind introduction and to the organisers for allowing me the opportunity to speak at your meeting. Over the course of the next 15 minutes, we're going to look at when to prolong and when to stop CPR. In terms of just briefly touching on conflicts of interest, I've received research funding not directly related to this topic from a number of UK funders. I also have a number of volunteer roles with the International Liaison Committee for Resuscitation, European Resuscitation Council and the UK Resuscitation Council. I'm also the editor, or one of the editors, for the journal Resuscitation. So what I plan to cover over the course of the next 15 minutes are the answers really, or at least my thoughts around these three key questions. Is firstly, what is the overall goal of resuscitation? What are we aiming to achieve when we start CPR? What are the factors that inform or influence our decision to stop CPR? And in particular, what are the various definitions of futility? And then to get into the meat of the talk, I shall look at factors to consider around prolonging CPR from the perspective of patient factors, reversible causes, factors related to the event, and finally system factors. So starting by considering what is the overall goal of resuscitation, and I guess the goal of resuscitation is almost a pathway that starts with achieving a return of spontaneous circulation, that the patient then makes a full recovery and is able to be discharged from hospital to home, and finally that they're able to return to their previous quality of life and function. And indeed the information and the data that's come out over the last 2 to 3 years shows that we are able to return people close to their previous quality and function of life. The decision about when to prolong and when to stop is actually a complex decision, and it's not a decision that is based solely on science and publications. It's a decision that interacts with the ethics of resuscitation, about the factors or the system that we have available and the resources and general approach both from the system but also society expectations about how far we go in terms of prolonging resuscitation and trying to save a life. And that will vary between health system and health system. I've asked the question at previous meetings. I've asked people to show hands as to what they would define as futile. So when would you decide that it's not worth continuing resuscitation? And it's interesting, in previous groups, there'll be between 50% chance of achieving a return of spontaneous circulation, to some people going all the way to a 1 in 1,000 chance of achieving a return of spontaneous circulation. And so some of the ethical elements come around what's the decision point at which you're going to say, well, actually, we don't have any chance now of restoring a circulation. And at least the European Resuscitation Council guidelines, which were informed by the European Committee for Medical Ethics, in the ethical literature that there is a concept of medical futility around 1%, and from Schneiderman, the medical community or society at large may prefer longer or shorter odds, but in the end we all have to accept some empirical notion of medical futility or otherwise throw all common sense to the wind. So as I go through the talk, have that 1% threshold in your mind. Now, I said that there were 4 factors that I was going to consider around the decision about prolonging resuscitation, and the first of those is patient factors. If we look back to the 1960s, when Kohoven and Jude and Knickerbocker first described closed chest compressions, they had 70% permanent survival. And the reason was that this term, although not coined in this paper by them, that resuscitation was being applied to patients whose hearts were too good to die. In their follow-up publication, which included a series of over 100 patients, it became clear to them, and they communicated to us as the clinicians that are applying resuscitation, that not all dying patients should have CPR. Some evaluation should be made before proceeding, as the cardiac arrest should be sudden and unexpected, and the patient should not be in the terminal stages of a malignant or other chronic disease, and there should be some possibility of a return to a functional existence. These are data from the critical care literature, and it looks at patients coming into intensive care units, and you can see three groups of people here. At the bottom, patients with minimal disability prior to their critical illness, those with mild to moderate, and those with severe disability. And what you can see quite nicely here is that after your event of critical illness, that actually your functional capacity, although it may return to baseline if you had a significantly impaired capacity or if you had severe debility before your period of critical illness, that's the state that you would be returned to. And if you look at the mortality across those groups, and these weren't patients with cardiac arrest, these were patients becoming critically ill, but the concepts certainly apply to cardiac arrest patients, that those that prior to the event of critical illness or cardiac arrest that have the greatest comorbidities are those that are least likely to be salvageable. And if we look at the literature in terms of patients that receive resuscitation in our communities, is on the left. This is information from our paramedic trial, which was run in the UK, and it shows that a large proportion of patients in an increasing frequency were having to contact health services and go to emergency departments in the days and weeks before the cardiac arrest. So these are not sudden and unexpected cardiac arrests. And data on the right from Denmark showing that 60% of patients, or 80% within 12 months, have been requiring frequent visits to healthcare facilities prior to their cardiac arrest. So I think the take-home message from these slides is that resuscitation is not going to reverse underlying illness and comorbidities. And so when making the decision to continue resuscitation, one has to have a focus or consideration to the functional capacity of the patient prior to their cardiac arrest. So to elucidate that a little more with some data on the left-hand side of the slide, people often refer to age as being a factor to consider. And I think what this shows is a combination, the improvement in survival rates that have been seen in Denmark, particularly in patients of a working age. Patients that have retired and in the late senior phase, so 10, 20 years after retirement, then their survival rates are lower, but their survival rates are not zero, as it's a 4% 30-day survival amongst the late senior patients. And indeed, when you look over on the right-hand side of a meta-analysis that had considered a number of papers, age hasn't come out as an independent predictor of mortality. It's actually the comorbidities and the factors that are associated with ageing that make the difference. Similarly, nursing home residency doesn't give a consistent effect on adverse outcome, and the review highlighted relatively limited research on the influence of comorbidities. Building on that a little, and this is from the American Heart Association, Get With The Guidelines. These were patients presenting to hospital who went on to have an in-hospital cardiac arrest. And they started to unpick, using classification and regression tree modelling, some factors that are important for predicting outcome. And so neurological function, so your cerebral performance category before cardiac arrest, if you had substantial impairment before, you had a low chance of survival. Things like sepsis, metastatic or hematological malignancies, also having adverse outcomes. Using a different group of patients, but the same authors and a different analytical approach, they were able to, again, describe a score, the GOFAR score, that takes the patient's comorbidities into consideration in predicting their likely outcome. So if you got a score greater than 24, where neurologically good function was a favourable prognostic factor, it starts to give you an idea of some of the things that are going to identify your patients with the best chance of outcome. Of course, taking all of this together, one needs to consider it in the context of an overall resuscitation episode and whether there are clearly reversible causes, because I think one indication for prolonging CPR is where there are reversible causes. So moving briefly on to event characteristics, these are data from Canada, and it was an observational study that looked at the characteristics of patients that survived after being taken into hospital, and they identified if the cardiac arrest was witnessed by emergency staff, if a shock was given, and if there was any return of spontaneous circulation, that those three factors were very good at predicting outcome. And when they went on to test this in a prospective observational study where all of the patients were taken into hospital without termination of resuscitation, they were able to demonstrate that that model had very good precision in terms of identifying cases where it would be futile to continue resuscitation. They were able to add on to their termination rules some additional factors, that if the EMS response time took more than 8 minutes, and if the cardiac arrest was not witnessed by a bystander, that they were able to increase further the positive predictive values of their model. But the consequence of that would be that you'd be transporting more patients to hospital. Moving forward now to consider the duration of resuscitation attempts, I'm just going to pick on a couple of studies to illustrate this point, but this was an observational study from the US, and it was able to demonstrate the time to return of spontaneous circulation, age, whether the event was witnessed, whether it was witnessed by EMS staff, and the EMS response duration and initial shockable rhythm, noting that really the initial shockable rhythm is the most strongest driver there. And then a really informative study that was referred to yesterday by my colleague, again emphasises these points in looking amongst a cohort of close to 10,000 patients, what are the factors that seem to influence the chances of survival. So you can see here the probability of survival based on whether it's shockable or non-shockable rhythm, that really the group that have the greatest chance of survival are those with shockable rhythms. And over on the right-hand side of the slide is the same data, but rather than survival, it's favourable neurological outcome. And they went through and they looked at a number of different patients, and in fact, indeed, this is the Rock Prime study from the American Heart Association and Resuscitation Outcome Consortium, again showing this message that patients that have a shockable rhythm have a much greater chance of surviving with a favourable neurological outcome. Similarly, if the event is witnessed, if bystander CPR has been applied, and this shows a lesser effect, but nevertheless an important effect related to EMS duration. And then finally, they've taken all of those factors together for patients with shockable rhythms. And I think you can probably, or at least I see in this diagram, that the light grey lines are the 95% confidence intervals, that really none of them up until about 35 minutes start to cross into the area of futility. So for shockable rhythms, I think a clear drive, and particularly the first two there, shockable rhythms and shockable witnessed, good evidence that if you were going to prolong CPR, they'd be your cases. And look, by contrast, at the poor outcome for patients with non-shockable rhythms. Again, if you were going to pick anything out from this, it's the fact that the cardiac arrest has been witnessed as one of the key elements that identifies better chances of survival. So moving to the last 2 or 3 slides, it's a combination of system and society expectations. And this is to really note that between different communities there are different expectations of how long you will prolong resuscitation. So we heard in the first speaker describing over 1 million cases from the Japanese cardiac arrest registry. Well, in Japan, they're not allowed to stop resuscitation. They have to bring the patient into hospital, which is one of the reasons that they have overall such small survival outcomes, because they have to resuscitate everyone and they have to take everyone into hospital. Yet in other systems, in the UK system, in many parts of the states, that there are criteria for which you either would not start or you would discontinue resuscitation. I then moved to the concept of emerging technologies, and just highlight here that my talk hasn't been to talk about ECMO. We heard in yesterday's resuscitation a number of excellent talks, but it's to highlight that there are emerging technologies, although many of the concepts presented in this lecture I think will have particular relevance and attention to patients undergoing ECPR. And then my penultimate slide is to highlight some of the society challenges and some of the system challenges. And the left-hand side is a diagram from a Spanish coronary bridge syndrome, where the concept is a patient's brought into the emergency department with mechanical CPR, and then there's triage to either prolonged CPR or organ retrieval. And the criteria that make the distinction, are really fairly close, and an ethical analysis has really highlighted some of the difficulties that we're going to face going forwards about what the outcome of resuscitation becomes. So if I can finish, he's not going to let me finish on my summary slide, but I had a very nice summary slide in the last 10 seconds that was going to summarise the key considerations. But I think if you think about them in terms of patient factors, patients that were fit and healthy beforehand, patients that have shockable rhythms where it's witnessed, where they've received bystander CPR, or where there's a reversible cause would be the key considerations where I would prolong resuscitation. Thank you for your time and attention.